Hello, everybody. Hope that you're doing well. Welcome to week four, second year, week four. We'll have our first exam coming up in about another week or so. We'll have one more lecture, and then you all will be prepared for your first exam. So today we'll do a quick overview of what we had covered in week four. We did an assessment of respiratory function, went over the likes of review of pulse oximetry, capnography um, and the like. So we'll go ahead and continue to get started with that. We did have our learning objectives. Make sure that you do pay attention for that arterial to end tidal CO2 difference as we're moving forward. That'll help out a little bit next week when we start to talk about optimum PEEP. Uh, so we'll just keep cruising along. We did talk about pulse oximetry that it utilizes infrared light, right, and red light. It's got a LED in it as well. And then we talked about the difference between fractional and functional hemoglobin. We also talked about various dysfunctional hemoglobins, and we'll talk a little bit more specifically about the degrees of hypoxemia, the differences between hypoxemia and hypoxia next week as we get into that lecture. This is a lot of review of what we've done earlier in the program, so you know what limitations pulse oximetry has to it. Uh, if you've got someone that's been pulled from a burning building, they may have carboxyhemoglobinemia, so carbon monoxide or hemoglobin has an affinity for carbon monoxide 210 times greater than that of oxygen, so carbon monoxide binds more readily with hemoglobin. Uh, so pulse oximetry could only basically be able to determine that something is bound to the hemoglobin, but can't distinguish what is bound to the hemoglobin. So with that, you have it would give you a false high reading likely. So at that point, you would want to do an arterial blood gas, not only assess the PaO2, but to look at the levels of carboxyhemoglobin and so forth. You would also ask for a co-oximeter to be run with that, or the TMC may refer to that as hemoximetry. Uh, so we'll keep going. We also talked about those items that can move your uh, oxygen dissociation or the oxyhemoglobin dissociation curve to the right or to the left. So remember your acidotic type situations are going to cause a right shift to that as opposed to where more of an alkaline environment would cause a left shift of that oxyhemoglobin dissociation curve. We did talk about the use of colorimetric devices, waveform capnography as well. The reasons why we would employ such things as capnography while we're looking at CO2 presence and so forth. We talked about side stream and mainstream uh, sampling devi uh, sampling devices for our measuring end tidal CO2. Uh, we also talked about the advantages and the disadvantages of each of those. I did point out that it's important for you all to remember the phases of the capnograph as we look at it there. And you've got different things where we can talk about where you've got normal VQ or ventilation and perfusion. We can also talk about areas where you may have hyperinflation or issues with things that cause more of an issue with ventilation or things that cause more of an issue with blood flow or perfusion. And we also looked at the various types of waveforms that we might see with our capnograph patterns. With ACLS, we talked about utilizing waveform capnography to monitor our CPR. End tidal CO2 may run around 10 or so when you're doing your compressions. And if you have a spontaneous or a sudden jump, that can indicate a return of spontaneous circulation. So we're achieving ROSC at that point. Um, we also talked about the single breath CO2 curve as well. So there may want to pay a little bit of attention to that as you're studying and preparing for your exam coming up. Exhaled nitric oxide monitoring, we talked about that, the role it has with asthmatic patients, which not that children are the only ones that have asthma, but that's why you see the pediatric patient in the photo there. So if you're looking at the exhaled nitric oxide, we can see that we would utilize that for your asthmatic patients and COPD patients as well. Transcutaneous monitoring we've covered before in the past. It'll be covered more so in your neonatal pediatric course. And this week you went into fetal circulation. So with fetal circulation, you went over the various shunts, uh, the transition from intrauterine life to extrauterine life, or fetal circulation to adult circulation, essentially, the transitions that occur during that, and hopefully the pressure changes that take place, so that we do go from fetal circulation to adult circulation, beginning after the baby's birth, cords clamped, and they take their first breath. We also talked about the how difficult it likely is for the first breath to be taken because the surface tension at that point would be greatest because you've got the fetal lung fluid in those in the patient or in the baby's lungs, and they're trying to fill them for the first time with air after they come out. So those are some things that you would have gone over this week in 214. We did talk about indirect calorimetry as well and the importance of making sure that we understand how much energy is being expended while we've got a patient that's intubated, mechanically ventilated. Too many calories can equate to too much CO2 production, which can cause some asynchrony with the mechanical ventilator, uh, and vice versa. Too little calories can lead to muscle wasting and so forth, and make it even harder to liberate the patient from mechanical ventilation. So those are definitely things that we had talked about. It is important to remember things that might create more of a hypermetabolic state versus those that might create more of a hypometabolic state. Some equations that we had gone over, like you said, I had pinpointed the equations that you're going to need for your upcoming exam. These you should look over, be familiar with, but I'm not going to have you perform any of those listed calculations on the upcoming exam. These formulas, however, yes, you definitely want to make sure that you pay attention to those formulas and can utilize them when applicable in a scenario that may be provided to you here in about 3 or 4 days when you take your exam. And then we see some standalone CPAP unit there on uh, the left versus where you have the placement of an endotracheal tube. So we're doing CPAP through the ventilator. So you can see on the right there's a wider graphics, which basically represents having to overcome the uh, airway resistance established by the endotracheal tube or the artificial airway. So we had keep that in mind. Um, And then there can also be some transdiaphragmatic pressure that can be dependent upon where you work. You may see some of that in the future as well. So that's going to wrap up week 4. I know it was relatively quick. I try to keep these things as short as possible. I know that we've got 3 to 4. Well, our class is an all day event on Tuesday, so I'm trying not to be overly verbose, but just kind of hit the highlights of what we've done given that we spend such a long day together on Tuesdays. Thank you for your time. I hope you have a good weekend.